Welcome everyone to the Buyer's Table, the Health Tech Edition. I am Leandra and I run platform and network here at Forum Ventures. For anyone who isn't familiar with us yet, Forum Ventures is the leading early stage fund, accelerator, and AI venture studio for B2B startups. We were founded in 2014 with a mission to make the founder journey easier, more accessible, and more successful for the very earliest stages. This year alone, we'll be investing in about 55 companies, and we're also building companies from scratch through our venture studio. So if you're a founder or you know one in health tech or any great space, we'd love to talk. A quick context on what we're doing today. This is not a pitch competition. 6 early stage founders are going to present directly to a panel of enterprise healthcare operators, and our judges are going to respond the way that they would in a real vendor conversation. So they'll be asking honest questions, they'll give real reactions. This won't be investor theater. We really want everyone to come away with actionable advice and feedback about what this process would really look like. So on our panel today, we have Jeremy Rogers, who's the Vice President of Patient and Consumer Experience at IU Health, Zain Ismail, Director of Strategy Advancement at Walmart Health and Wellness, Philip Eves, President and CEO of Ascension Seton Health Alliance, and Kevin Yee, Vice President of Medical Services at Henry Ford. Thank you all so much for being here and sharing your time and feedback with founders. So we've got 6 companies presenting today. Each company will present for 5 minutes, followed by 5 minutes of Q&A and feedback from the judges. And we're going to get started with our first presenter.
Okay, hello everyone. My name is Marisse. I'm the founder and CEO of Iriscience. I am a clinician scientist by training, and the idea to get this company was from my own practice, where in ophthalmology and specifically glaucoma, that is my specialty. By the time you see people with glaucoma and they have symptoms, it's already too late. So in that sense, 50% of the people who are blind in the world are blind because they didn't get timely access to healthcare, which is not only a huge human cost, it's also very expensive for the payers and the insured companies. And this problem is complex, it's three-tiered. First of all, as we know, the population is getting older. We don't have enough specialties to cover that population, specialists, I'm sorry. And even if we did, it is a matter of reaching out people where they are, because a lot of people don't know that they should have, after 40, one eye exam a year, which is not the same as getting your refraction, your glasses. Another issue that we have is that there is a huge burden in the clinician side. If we manage to get the patient in, the patient managed to get an appointment. Most of the time that we're doing these consults, it's dealing with paperwork and electronic medical records. So that's time that the specialist needs to do, and it would be better applied if we were having face-to-face time with the patient and the more complicated cases. So our solution is that for screening, we're taking advantage of already available hardware. That's very important. There is excellent hardware that has been developed in the past 5 years, and we are using AI models based on robust data sets in introducing our software to this hardware to facilitate screening and remote evaluation. We did a trial with the University of Rochester, and about 80% of the people that we see in the community can be solved there with telemedicine, and only the 20% had to be seen in person. We're starting with software to detect cataract, which is the most prevalent cause of preventable blindness. And then we have glaucoma, macular degeneration, and diabetes to get the full package of the main causes of blindness. And our North Star is to use the eye as a gate for cardiovascular health. So the way it works, the patient, we capture them when they're in pharmacies or where they go to buy their glasses. We offer them our 6-minute examination, and we do a pre-screening. It is very important that the clinician is in the loop. So at the end, these reports that were generated, at the end, they're validated by the ophthalmologist, who at the same time are being reimbursed with the codes that already existed. We integrated this in our electronic medical record that we did specifically for ophthalmology with a PAC system, which is an image manipulation that is very specific for specialties that have images. And we have built the architecture with all the security and compliance, which you cannot build fast and break fast in cybersecurity. this electronic medical record is already being used by clients outside the US. So at the end, like our solution decreases from 25 minutes normal screening to 6 minutes, which the specialists can validate remotely. We are attracting people who are not easy to get into the office, and we're already using existing billing codes for this. And at the end, part of the big advantage that we had is that we have this flywheel using the solution to also curate data. So we're validating our models in real time. We have a SaaS service model that it is tier. So we have the basic service. We have a medium one that is for telemedicine. And then we have a more advanced tier that it's for the most sophisticated models that we have with the databases that we're getting. We have a multidisciplinary team. We're a team of 6 people, the engineers and myself, to run the clinical trials to build this data set and to provide the AHR that is already being used. Thank you very much.
Thank you. Okay. We have all the judges here. Wonderful. Okay, we're going to do just some quick rapid fire questions. So you're going to hold up your fingers 1 to 4, 1 being not at all, 4 being very much. Okay, so the first one, how urgent and costly is this problem for your organization? We got 3, 3, 1. Okay. The second question, how likely are you to actually pilot or buy something like this in the next 12 months? Okay. And finally, how well would this fit into your existing workflows without creating extra work for your team? Okay, great. So let's begin with questions and feedback. If you're asking a specific question to dive in, maybe you can explain more why you're asking the question so that we can understand what you're thinking as a potential buyer. So if anyone wants to jump in, feel free.
Well, thank you for your presentation, Marisse. Curious, who can ultimately use your solution? I know you said it was a non-clinician, but any more guidelines around that? And so the reason why I'm asking is, at Walmart, we don't hire a whole lot of doctors. We do have a lot of pharmacists. We do have a lot of ophthalmologists in our vision centers and so on and so forth, and then techs and so on and so forth. So just really curious who can actually use your solution. And I'm trying to map out, to what degree could Walmart maybe take advantage of your services.
So actually, for example, Walmart would be a key partnership. We have in the pilot we're doing in Rochester, we would be a nurse, a tech can do the exam. And then the other part of the equation is the local clinician that validates it because it's not fully automated. And also that's also increases the trust in the clinician. So with the University of Rochester, we have a partnership with U Rochester to validate these tests. So we can do these with local pharmacies and places in the community nursing homes.
Got it. Thanks.
Hi, Marisse. This is Kevin Yee from Henry Ford. A couple things. So I looked up your company. I think you need to emphasize that yours is video-based versus static images because there are a lot of competitors and your presentation didn't go into that. And that's an advantage, right? The other thing is I think you need to emphasize it's a smartphone platform versus specific manufactured made equipment, meaning you can take this into the community. And then the third thing I think you need to look at and possibly work into your pitch is how does this help with CINs, integrated networks, right? So physicians are measured on compliance for measures. So you didn't address in your pitch how this device could help a clinically integrated network meet those measures. So please take that into account in your next presentation.
Thank you so much. And I literally removed half an hour. I was practicing the pitch I'm in DC in a conference and I practiced and they said, you should remove the video. That's too technical. It's part of our mode. So that's funny that you put me in the spot. Yeah, it is also a smartphone based. We're using FDA approved adapter, which is also important that we lease if the partners don't have it. And the integration, that's part of the study we're doing in upstate New York. So we can do the economic analysis, but those are very valid points on that because it is easily integrated in organizations that already have community outreach in the pipeline. If they don't, then it is an admin process that we have to go through.
The next question. My name is Philip Eves. I'm from Ascension. Just to tag on to what Kevin had mentioned, I think for a health system, being that value-based care is only becoming more and more of our future. I think being able to show how does this help close quality measures, how does this impact total cost of care, I think is important to incorporate in the value proposition to any health system, just because we're being held accountable more and more by the payers, by the federal government. I feel like what you're doing here is good. I think it's going to help increase the eye exams, hopefully get a little more proactive, which will help control spend, I think, long term within the population. But that would be my only feedback.
And Marisse, I would just add, again, to piggyback on Kevin and Phil, I think, oculomics is an awesome space, especially in the health system. I think the debate we've seen is like the role it's played in primary care versus ophthalmology specifically. And in a primary care office where we see most of those patients, the throughput is a challenge. Like having staff trained to use devices like this has been a big burden over the years. But I do think it's an awesome space, a great addressable market.
Yeah, I agree with you. And in primary scale right now, we have high-risk measurements for diabetic retinopathy. Like we don't have codes yet for oculomics. So that's why we're starting with the research component with our clinical partnerships for the piloting. So yeah, I think like once you have the patient there, diabetic retinopathy should not be the stop. We should get the whole battery of exams, and oculomics is not far away. Like we already have a first software for that, and it's going places.
Okay, that takes us to time for this presentation. Thank you so much, Marisse. I'm going to put you off stage and bring on Cathleen of Opalite Health.
Hi everyone, I'm Kathleen. We're Opalite Health, an AI medical interpreter that helps healthcare providers communicate with patients who can speak English. A little bit background on myself first. I'm a physician by training, graduated from Sunny Buffalo Medical School in New York. I'm also an immigrant myself. Both my parents don't speak any English at all, and my mom actually got a really serious complication a few years ago because the interpreter mistranslated her symptoms. That's what made me really passionate about finding a better solution to support this patient population. And for my co-founder, Alex, he's also an immigrant himself. His mom is actually a pulmonologist from Russia. So he has been learning and then hearing about all the language barrier issues growing up. And I'm sure everyone heard about how language barrier can compromise patient care. And not only just influence the outcome, but also it's a very costly problem to have. It's a very costly solution to have because from our talk with multiple health centers and also hospitals, currently they are paying between $5 million to over $10 million every year just on interpretation itself. However, they are still getting a very inconsistent quality of interpreter. And also there's sometimes long wait time, especially for those rare languages. And that's why we are building Opalite. It's an AI-powered medical interpreter that does real-time speech-to-speech interpretation for over 150 languages and dialects. And it's 24/7 instantly available. I will go into this a little bit more during the demo. This is just a gist of what Opalite is. And I'm sure everyone is asking about how can you trust AI to do this such a high-stake clinical conversation scenario. That's why we did a study with Johns Hopkins Medicine, comparing our AI model with the certified medical interpreter, which is the gold standard right now in healthcare. And we found that not only Opalite is the preferred solution, but also we reduce major and critical errors by over 90% compared to certified medical interpreter. And also another really interesting thing we found during the study is we are able to shorten the entire clinical appointment conversation by about 20%, which is equivalent to about 8.3 minutes. And Opalite has been used by leading healthcare organizations such as CVS, Mini Clinic, we're going to roll out there, Cleveland Clinic, multiple hospitals, and also dozens of community health centers. And let me do a very quick demo. This is the right window. So Opalite can be used on any platform. We can be used on a phone, a tablet, the laptop, computer, phone line, even landline phone will work, and also telehealth such as Zooms, Google Meet, Teams, etc. So pretty much every clinical scenario will work. And when you come in, usually we integrate into your EHR, so the provider will be able to see their entire patient list on Opalite itself. And super simple, just select the language. Like I mentioned earlier, we support over 150 languages and dialects. And we train all the model ourselves to make sure that it's really good at translating medical terminology and also the cultural nuances in different dialects. That's why, for example, for Spanish, we support 8 different dialects. I'm going to use Chinese since I speak Chinese. And just press start and just wait until we connect to Wi-Fi. You have an interpreter on the hand within a second. 我从昨晚开始就觉得全身很不舒服，头晕想吐，然后好像还有点发烧。I'm so sorry to hear that. Can you tell me more about what's going on? Do you have any abdominal pain? So you can see it's super simple, very fluid, just go back and forth with the patient. And instead of like talking to a human, it's a total black box. You can see the entire transcript, what's being said, what's being translated. And afterward, after each visit, it's also act as an AI multilingual scribe as well to be able to generate a note. Since we didn't really talk much about it, this is a simple note that you'll be able to generate based on the conversation, and then one push everything directly into your EHR. And that's all about Opalite. Thank you so much.
Thank you so much, Kathleen. Okay, we're going to do the quick rapid fire questions. How urgent and costly is this problem for your organization today? How likely are you to actually pilot or buy something like this in the next 12 months? And how well would this fit into your existing workflows without creating more work for your team? Okay, I will let you all begin with your feedback.
So you can use this in like ERs and AM-surge places without another person interpreter there. So it meets federal regulations.
Yes, we are Section 1557 compliance, which means that we do have human.
So you probably should mention that. Okay. The other thing is, what's your payment model? I didn't see anything like in your presentation about that. And in terms of implementation, talking like, is there some IT interface or like how easier, if you could mention that those would be 3 questions I would have asked, and most likely you should have answered in your presentation.
No, thanks so much for the great point. In terms of the cost, we cut your interpretation cost by at the very least 50 to 70%.
No, I know. I read about you guys, so it's pretty impressive, which is why I raised my fingers that I'm interested, but we have a system, but you didn't mention it in your pitch. But you mentioned that you would get people to think, and it's not going to be a year, it's not going to be an immediate transition because most of us probably have a contract with a vendor already because we have to provide this service. So what is our clause out? 90, 120 20 days out. So you just need to understand that.
Got it. Thanks for the feedback.
And to Kevin's point, I think anytime you try to sell to a health system, many times it's 12 months to get in, right? I mean, it takes a while. I do know that there is a need for something like this. I mean, I've seen expenses around what we, are charged around these type of services, and it's a very manual world we live in. So it'd be nice to have something AI, focused that could kind of take this lift. Another thing, just to some feedback, is EHR integration is always a challenge. So understanding which EHRs you're currently working with today, where there would be a seamless integration and it wouldn't be a big lift, I think would be good to understand from a health system perspective. Obviously, there's a handful of very large EHRs that are used in the market, so I think mentioning those, if you already have those interfaces, would be important.
Got it. Yes, we
I can go
integrate.
next, Kathleen. I love the approach. Go ahead, please.
Oh, no, I'm just saying we integrate into all the major EHR, Epic, Cerner, ECW, Athena, NextGen, everything. Yes, sorry, Jeremy, go ahead.
Yeah, no, that's super important. I agree with Phil there. I think, I love this space. I've looked a lot at it in recent months. I think that the debate I see is a lot of bigger language services vendors are attacking this space too. And the question I have is this really a product by itself or a feature? A lot of what I hear is we need to have this more directly embedded in the EHR workflows versus being a third-party punch-out tool. I think that the models you have, the approach you have is awesome. But I think for big health systems, the debate is, do we buy this separately or bundle it together with other capabilities?
Got it. Makes sense. It's a lot harder to build than what people think about, especially the accuracy and quality of translation is so important.
Good comment, Jeremy. On my end, Kathleen, I'll just confess I don't know on the retail side where we're really at with translation service. I know we have it, and then I know, we operate more on the low acuity side of the healthcare value chain, and so I just wonder if your product is more well positioned for my colleagues here in the acute care, proper health system space than retail. But I did take note that our competitor, CVS, is working with you all, so maybe we can chat offline and learn a little bit more.
For sure. We'd love to. Thank you.
Well, thank you, Kathleen. Thank you, everyone, for your feedback. Next up, we have Alexandra. I'm going to bring you on stage. Okay, are you ready?
I sure am. Hello, everyone. I'm sure you could hear me. Wonderful. Sounds good. Well, good afternoon. I'm Alex Grullon with Blooming Health. I'm one of the founding enterprise account executives here, and we build care enablement workflows. That looks like outcome-driven automation that closes the gaps in care coordination that manual outreach can't scale to cover. So here's the problem that we're solving. Healthcare organizations aren't losing money because of clinical skill. They're losing it because of care coordination, which falls through the cracks. So we see excess 30-day readmissions cost the industry over $17 billion a year in CMS penalties alone. You guys know these stats, but kind of reiterating here, 69% of Medicaid disenrollments aren't because someone became ineligible. It's because of procedural, missed paperwork, missed deadlines, and so on. And then every star rating point is worth $10 million plus in reimbursement for a health plan. The root cause is the same everywhere. Care coordination can only reach 30 to 40% of discharged patients within the critical 48-hour window. And as we know, and I'm sure you all know, manual outreach doesn't scale. So that's why we built the Care Enablement Workflow, a CEW for short. It is not a chatbot and it's not a call center replacement. It is an end-to-end automated care pathway made up of 4 parts. First, a real-time trigger. That includes a life event that could look like a discharge, a renewal deadline, or a care gap. Then an AI agent will engage the patient by voice or text at the right time in their preferred language. And additionally, and from there, the agent is going to actually take action. So it schedules the appointment, it books the ride, it sends the referral, and it follows up. And then lastly, we obtain a measurable outcome that gets written back into those EHR systems, EMR systems. It's not just a conversation, it's a completed outcome. So these are the 6 focus areas that we cover today that are aligned with the current priorities and gaps the health systems and plans are looking to improve. That does include improving maternal health outcomes, care transitions, benefit continuity, including Medicaid, SNAP, and other benefits, primary care access, so getting folks to those annual wellness visits, those health screenings. Additionally, chronic disease management, so really providing that ongoing care and intervention and gap closure. And then lastly, addressing social determinants of health and being able to fully close the loop. Here's what that looks like in practice. So the moment a patient is discharged, our agent is triggered by an ADT feed, and it calls them within 24 hours, not the 30 to 40% manual outreach that is able to reach. It's able to reach the 100% of patients. So over the following week, it will confirm when medication has been picked up. It'll be able to help schedule a PCP follow-up directly through the EMR, or it can facilitate a 3-way phone call to the call center if there's one available. It can also screen for needs and refer to a community-based organization. So throughout this conversation and engagement, if there's needs to be detected, the AI agent is proactively addressing that and being able to connect them to those proper resources. And then additionally, it closes the loop. It is able to fully confirm that the referral was not only addressed, but that the need was resolved. So every misstep automatically re-triggers outreach. And that's the difference between logging a problem and solving it. So this is really the core of why we exist. Most vendors in this space, included well-funded ones, they build a single agent that calls a patient, it checks a symptom, and it logs it. Then a human has to pick up from there. So that ride for the doctor's visit never gets scheduled. The missed follow-up sits for weeks. The social need never turns into a referral, and so on. We built the orchestrator that sits on top and coordinates everything. It's able to coordinate across tasks, channels, and time. So if a patient mentions to a transportation that there's a transportation barrier mid-call, the orchestrator pauses, it hands off to a transportation agent, books the rides, and returns to the conversation. If a lab result never comes in, it re-engages automatically within day 7 and so on. Briefly, just want to touch on, none of this matters if it isn't safe. Our agents never diagnose, they prescribe, or they recommend treatment, full stop. Every single action is traceable to a rule that your clinical team defines, not agent autonomy. Any crisis escalations that exist, it is escalated to a human immediately, and so on. Last thing that I do want to cover is the math. So a health system with 10,000 discharges a year, moving 30-day readmissions from 15 down to 10% is 500 fewer readmissions. At roughly $12,500 average cost per admission, that's about $6.2 million in avoidable costs eliminated annually. And additionally, as we knew, moving the needle when it comes to a star rating, that's about 10 million plus. Where we actually are, we are across several organizations today, but being piloted around maternal health, deployed within health systems today for university health systems, and along with that, really supporting FQHCs around benefit renewals. And that's the end. I hope I was able to do that in 5 minutes.
You got it, Alex. Thank you. How urgent and costly is this problem for your organization? Okay, we got some 4s. How likely are you to actually pilot or buy something like this in the next 12 months? Okay. And how well would this fit into your existing workflows without creating more work? Okay, thank you. I will let the feedback begin.
Maybe I'll just
I could
go ahead.
Yeah, go ahead, Zane.
Okay, well, I don't think this is Walmart space at all. So
Okay.
Health system colleagues.
Yeah, so Alex, this is a space that I feel like I'm living in every week right now. We're running pilots across our organization in every state. And what I'm finding is there's a lot of people involved in these processes and these pilots. I don't really have any feedback for you. I would just love to have like a conversation maybe at a soon date just to talk through this, to understand, how this could potentially fit into something we're doing here at Ascension. Maybe we could find a place to do a pilot, but I do think this is an area that's vitally important to our organization right now.
That's a success. Thanks, Phil. Happy to.
Yeah.
And Alex, I would just add there, I think I love the approach. I mean, we're in a different spot because we have big investments in both our EHR and CRM platforms that do similar care gap orchestration for us. I think for smaller or medium-sized systems who don't have those kind of legacy and incumbent platforms in play, I think it's much more turnkey for them. But for us, we're just kind of beyond that phase at this point.
Yeah. I'm interested. I think it's a great product. The whole closing the loop, which is something that a lot of products don't do. Slide 4, I was looking for dollars. You separated it, I think, on the slide 8. And I think if you could combine it, you piqued my interest. But then I wrote, what are the dollars? You answered it, but it was too late. Kind of, and I also think you need to go into more, how do health systems or hospitals pay for this service? No, yeah, you can't, unless you, and I know you only had 5 minutes, but if you're making a pitch to executives, we understand it's not free. So how do we get it? And that's my question. You didn't quite get into. Obviously, when you spend more time with Phil, you'll be able to do that. But to pique our interest, you got to tell us, like, there's Medicare waivers, right, that pay for this. So like if your state participates, it's zero cost to you, so to speak, or however you got to explain that to us so you hook us in financially as well as the product itself. The product speaks for itself, so now you've got to hook us in otherwise. And I think Bill and Jeremy mentioned before, different company, what's the IT hookups that you need? Those guys understand it way more than I do, but they said it's a big process. So do you understand that, and can you just speak to it? So we would have, I guess, awareness that you acknowledge that there's work to be done, so to speak. It's not like a turnkey type thing in 60 days.
That's a great point. I appreciate that, Kevin. We work with LK, which is our integration partner, which allows us to kind of scale that. And to your point, create a little less, operational lift. But I really appreciate your feedback surrounding like our ROI model. I do think that some of the conversations and pitches I've had lately has been centered around how exactly are you going to pay for that. So I appreciate you kind of sharing your notes around being more defined around what that looks like. So thank you. Yeah. Jeremy, you did mention that right now there's some of the, you already have some kind of legacy solutions that you have in place. Are any of those AI centric? Is that agentic workflows? And are those partners developing that? How does that look like?
Well, great question, Alex. I think it depends how you define agentic. I mean, every vendor has an agentic slide, but is it truly agentic? The answer is probably no. I think we're trying to come at from the opposite direction. What is the clinical care gap problem? What is the business problem? And then apply the agentic lens on top of that versus having an AI solution in search of a problem, if that makes sense. So I think for us, it's more of just how do we maximize out of box things that EHR offers, plus some of the deep CRM integration we've done. How do you weave those together to have a kind of more cohesive experience? That's kind of where we're at.
Understood, and appreciate that. I will say we are very much just agentic AI. So I hope that kind of gives a little bit more of the background on our end. We kind of work to support those care teams, but I appreciate your angle and we'll look to identify that in next pitches. So thank you.
Thank you so much, Alex. Next, we have Liz from Nolia Health.
Okay, hi everybody. This has been really fun. Thank you. I'm excited to be here. Liz Tarullo, co-founder and CEO of Nolia Health. And we deliver clinical guidance and mental health support for family caregivers of older adults living with chronic conditions. I got into healthcare over a decade ago when my dad had a stroke, and overnight, at a pretty young age, I was confronted with the question of how am I going to take care of an adult who can no longer really take care of themselves. And that's what led me into home working with dual eligibles, really investing in the paid caregiver experience for many years before joining Amazon to help launch and scale healthcare at Amazon across the country, kind of reimagining virtual care access. And so what we've built at Nolia is the virtual care model of family caregiver support that I wish that I would have had during that experience with my father, but certainly focusing on a clinically integrated approach that's focused on driving better health outcomes for both the older adult living with a chronic condition and the whole family system. We are a Medicare Part B enrolled provider, so everything we do is actually covered by insurance. So from a health system perspective, we come in as a partner really focused on collaborating with the existing clinicians that you have, but focused on a stakeholder and a member of the care team that's really the first responder in the home that historically just has not really been able to be fully engaged. And as our system, as our population continues to age and more people find themselves in the position of wanting to age at home, 90% of Medicare beneficiaries have a chronic condition, more than 2/3 have multiple chronic conditions. The onus of taking care of them really falls on this invisible workforce that is family members or neighbors stepping in increasingly to help really implement the plan of care following a diagnosis or an acute care episode. So you're looking at a situation today where 1 in 4 adults actually are taking care of an older adult. Less than 7% of them actually get any type of clinical guidance or training after a diagnosis or an acute care episode. And yet it's the work that they do to coordinate transportation, make sure appointments are actually fulfilled and attended, making sure that medications are taken in the home that drive the 80% of health outcomes that lead to the total cost of care. Most of them are cutting back on work. And what they need is clinical guidance and support. They need mental health support, with more than 60% of them experiencing burnout and stress related to caregiving activities. And they need all of this to be done in a clinically evidenced and validated way. So we are purpose-built for family caregiver engagement, again, focused on driving better health outcomes for the very patients that you're seeing. We work hand in hand with the clinical team following a pretty simple referral workflow where, medical records or the referrals being placed similar to a PT or OT or social work type of care coordination. And then we're virtual, we're conveniently accessible. We're in network with all, traditional Medicare and all the top MA plans. So the cost to the family is very low. Phil, I really appreciated your point earlier on VBC. So we do bill fee for service for kind of most of our services, but we also were accepted into CMS's new program, the GUIDE model, which focuses specifically on Medicare beneficiaries living with dementia, a value-based care program that we can deliver nationally that also gives families access to $2,500 of respite care and home care that's totally paid for by Medicare. So we have kind of a specialty and an expertise in older adults living with dementia. The way that our clinical team works, it's nurse practitioner led. We found that really helps to accelerate clinical guidance, training, care plan development, interpretation and guidance. We also support on the mental health front. So we have licensed clinical social workers that do individual counseling and therapy for family caregivers. It's a very psychologically overwhelming experience, and that's all covered by Medicare as well. And then caregiver training, both in group and individual settings. So how do you bathe someone with dignity? How do we talk to our children about memory loss? And all of that is facilitated by a licensed clinician that works hand in hand. So from a system perspective, we're already working with systems across the states that we operate in, but we integrate seamlessly with your EHR to coordinate referrals. Our care team does the outreach to the family caregiver. And what we're able to provide back to the health systems that we partner with is really a step change in clinical data. The home is kind of a black box. And outside of those provider visits that might be happening every 6 months, a lot can change and who's involved with care. And so providing that visibility from a trusted clinician was something that the providers that we work with really love. Like I said, the specialties that we've primarily worked with so far, primary care, gerontology, neurology, oncology, and complex care. We've also been accepted into Access, which represents a new financial incentive for PCPs to actually get Medicare beneficiaries into these chronic care. We can enable that. We're partnered with great health systems kind of across the country and supporting thousands of families. It's really important to us, the feedback we've heard from the clinics that we work with, that they hear from their patients how well supported and cared for they feel. Easy referral process, and we're a partner with them in ensuring comprehensive and compassionate care. And I think that at the end of the day is because we're clinician-led and we're focused purely on really creating a very supported and guided family caregiver experience in conjunction with the incredible patient care that our partners are delivering.
So we're going to do our rapid fire questions. How urgent and costly is this problem for your organization today? Okay. How likely are you to actually pilot or buy something like this in the next 12 months? How well would this fit into your existing workflows without creating more work for your team? Okay, please proceed with the feedback.
I really like this idea, but what I didn't get a sense from you is to convince me that I have a problem, right? But I don't know what I don't know, and your presentation didn't help me say, like, you don't know that this is a problem. So somehow you got to factor that into your story, right? That's why I gave it, like, you didn't change my mind that this was a problem for me. The other thing, mental health providers, they have to be licensed in the state and that you go into. In a lot of states, that's a recruitment problem. And so again, not that you had time, but how do you address that? What makes you different than a healthcare system trying to hire their own? So those would be two things that I would look for in your presentation in the future. But I really like the idea.
Yeah, just a crisper definition of how we're leaving health outcome improvement opportunity on the table by not engaging a workforce that's stepping in today and has no real connection to clinical oversight. To me, that ultimately is, it's like, yes, it's a problem. It's the fact that you have folks that are stepping in to fill a gap, but they are not being effectively utilized from a healthcare system perspective. But that could come through clear, and I hear that.
You need to make a story then out of it that then hits home to who you're presenting it to. Like, this became a problem, right?
Yeah.
And this goes on hundreds of times in your area. So I'm just.
Yeah. Thanks, Kevin.
Yeah.
Yeah. So this topic, it's interesting. I actually talked about this a little earlier today. I'll just say I'm not a fan of the guide model. We went down that path. I think I'm curious to see how long it lasts with CMS. But I do like the idea that you bill fee for service. I think that's good. There are some interesting groups out there that are doing similar things that have kind of stepped out of the guide model. I would say for the few pilots that we've run, we are now starting to see that kind of activating that at-home caregiver is meaningful, but it's also helping the primary care physicians understand what's happening in that setting. And so some of these programs are very disconnected. Primary care doesn't know that this exists outside of the practice. And so I think having some kind of feedback loop back to primary care, I think, would be important. One of the programs we've run that is occurring, and I think the primary care physicians find that to be very valuable. But I mean, I would definitely have a conversation with you, just because I'm trying to solve for this, and I have multiple paths I'm considering, but I'm getting out of some of the arrangements that exist today because I feel like there's been a lot of new startups that have chased the guide model, and it just hasn't been very successful.
Completely. It's a part of what we do. But from the beginning, have always said we need to meet family caregivers where they are, broad chronic conditions, and do fee for service in addition. But, we'll take the opportunity to participate in VBC where we can.
Yeah, Liz, I love that. I would just piggyback on Kevin and Phil's comments. I think what I've found in most big health systems, they don't talk about caregiver capabilities or experiences at scale. It's either a practice or a given provider. And so I think the challenge I see is opportunity cost, and most big health systems have like 99 priorities right now. How do we get this higher on the priority list? That's the struggle I see.
Yeah. Thanks, Jeremy. Love to figure that out.
Okay, we're just about at time. Thank you so much, Liz, and thank you all the judges. Next up, we have Royi.
So I'm Royi, we're MedComm, and we're closing the follow-up care gap. The problem is that heart failure patients are leaving the hospital when they're overwhelmed with instructions, without proper monitoring or follow-up. The result is that 1 out of 4 of these patients end up back in the hospital in the first 30 days. A physician we're working with has shared with us that she discharged a patient that was seeming stable. Then 5 days later, he came back and died on that same day. When she traced back into his phone, she seen that the patient did not pick up his medication when leaving the hospital, and when he finally did a few days later, he didn't know how to take them. And that preventable tragedy is exactly what we're trying to solve. And it's not just a problem for patients. The penalties for health systems are more than $15,000 for one readmission, without counting the operational cost and the missed opportunity. With an overall cost of care in the US of more than $70 billion. And hospitals are allocated care managers to do manual and repetitive outreach, but these are missed and not scalable. Our solution is MedComm, an AI native transition of care provider that is focused on those first 30 days post-discharge for heart failure patients at first. We're using phone calls and text messages to reinforce instruction, checks in on patients. But if we detect problems, we immediately notify the care team so they can intervene fast before the patient gets readmitted. Why we have the right to win? Because we're building this workflows with heart failure providers at Weill Cornell, and we're gaining evidence with research backed by Cornell, NYP, and Northwell. This is some of our results. When we're comparing back-to-back with an OpenAI out-of-the-box model, we're showing much better escalation accuracy of 100% compared to 72 hours from out-of-the-box, the same model, but generic prompt. Then looking at documentation completeness for these specific teams, we're also achieving much greater results. The same goes to safety policy violations. The more than 50% of violations for the OpenAI out-of-the-box model and 2% for us. Then under escalation or unsafe medication advice, the same metrics go there. We're focusing on the clinical workflows where these mistakes just cannot happen. We're piloting with NYP and Weill Cornell with active 100 patients that are being engaged for us to better iterate and improve our tools. We also have signed pilots with Lenox Hill and Weill Cornell Heart Failure Transition to Care team, and we're scoping up with larger population health organizations that are based on PACE models and value-based care arrangements. Why now? There are 3 challenges and 1 opportunity. One is that the heart failure population is growing rapidly, with 30% in the next 3 years. The government is putting a lot of strength and pushes a lot of pressure on health systems to reduce costs. Nursing shortage is rising, and the opportunity is that Epic comes up with their agent factory, giving a platform and an operating system to build workflows, but someone needs to actually take those workflows from the care team's minds and put them into actual workflows that can work, measured, and easily and safely distributed to patients. Our team has vast experience in AI implementation in health systems, and our advisors has deep clinical expertise and health system leadership. Thank you. Join us to close the follow-up care gap and save people's lives. And I'm here to answer any questions.
Thank you, Royi. Okay, let's start with the rapid fire. How urgent and costly is this problem for your organization today? Okay. And how likely are you to pilot or buy something like this in the next 12 months? And how well would this fit into your existing workflows without creating more work for your team? Okay, let's begin.
Royi, I jump in here. I think my comment similar to the session before in terms of the platform versus the vertical capability here. I mean, it's one specialty, a very important gap, a challenge we face, but the challenge is, do we deploy kind of vertical bespoke solutions versus like a common platform, either in the EHR, in a third-party platform? That's the big debate I see for a solution like this.
Yeah, we would struggle with that same thing, Jeremy. So you're right on for a bigger health system. The other thing is, I think maybe, and I don't know enough, but I know a little, so it makes me dangerous. Maybe you need to stratify the patient population you're going after, because the gold standard for heart failure is like a cardiomem, it's an implant. Yours is more, to me, maybe the basic 1 or 2 levels that health system deploy people to manage, and this could be a solution. So again, you're not trying to boil the ocean. You understand that. So again, you acknowledge that this can't do certain things, but it can do other things very well. And I would tailor your presentation to that. You may get more traction that way.
Yeah, I don't have too much really feedback for you. Usually I bring in my chief medical officer in cardiology to have these conversations and be candid. But I will tell you, CMS is through the ambulatory specialty model. CMS is starting to focus more, I think, on heart failure and trying to control total cost of care there. They've started that across various markets across the United States, but over time it will only grow. That's how they start their programs small, and then they blow up and they include everybody. So I think you're focused on the right problem, and I think there's going to be a lot of opportunity here, but I'm probably not the best to weigh in on how it fits or not. We've invested a lot of money in this space specifically, and I know we have a decent mousetrap at the moment.
Thank you.
Thank you so much for participating and for your feedback. And I am going to bring Sheena up onto the stage.
Hello, everyone. I am Sheena Franklin, the founder and CEO of Kebs Health, and we are a real-world data platform focused exclusively on the diseases and conditions that impact women throughout their lives. We connect directly with women to transform real-world health experiences into scientific insights that inform product development, reveal disease progression, treatment experience, and real-world outcomes. Our goal is to help healthcare organizations generate the evidence you need to make faster, better decisions. We help solve the challenges of fragmented data and repeated participant recruitment that forces organizations to rebuild evidence programs for every research question that needs to be answered, delaying innovation and driving up costs, from prospective studies that cost millions of dollars to patient registries that require more than $1 million to establish and maintain. To do this, we collect multimodal real-world data, so that's patient-reported outcomes and wearable data, and we combine that with electronic health records and hormone lab testing data to generate scientific insights, as well as to build the FEM index, which is our proprietary real-world data asset. And so each data source contributes a different part of the patient's health experience. So that's continuous daily activity captured from their wearables to a snapshot in time captured by a hormone lab test. Through this process, we provide a more complete picture than any single source alone, as well as any general population health real-world data platforms. With KEPT, you can generate patient insights, conduct prospective studies, recruit participants, and access real-world data that captures variables traditional data sets miss. These capabilities can be used by various teams across your organization. So that's clinical research, population health, medical affairs, intervention, innovation, and even digital health. Our work with United Healthcare demonstrates this approach in action through a self-reported outcome study at a large lifestyle festival. We engaged directly with 3,000 women to validate emerging observations and uncover insights within their claims data. Another example of our work is with Johnson & Johnson Innovation to support their research and product development, where we designed and tested data collection methods, resulting in an internal collection for data guide for Neutrogena 360. And we laid the foundation for a diverse psoriasis patient registry. And here's why these companies and others are looking for solutions like KEPT. First, there's an increasing pressure to demonstrate the business value of investing company resources into women's health initiatives. Next, regulators are placing greater emphasis on real-world evidence with increasing expectations of diverse data and sex-specific insights. And lastly, AI requires a higher quality representative data set today than it did previously. This is the future that we're building here at KEPT with a team that brings expertise in industry and legislative affairs, clinical practice, and technology. So that's my quick presentation, and I thank you for your time, and I look forward to our discussion.
Okay, let's do our rapid fire questions. How urgent and costly is this problem for your organization today? Okay, we got a 4 and some 1s. How likely are you to actually pilot or buy something like this in the next 12 months? Okay, and how well would this fit into your existing workflows without creating extra work for your team?
2.
Okay, this is our last feedback round. Thank you, everyone.
Hey, maybe I'll start. I was on the opposite side of where the hospital colleagues are, but this is the business that we're in, scaling up Walmart's clinical research capability with women's health being one of our priorities. So I don't have a whole lot of feedback, but would just love to connect offline and go even deeper and learn more and maybe chat with some of our actual data experts who would know this a lot deeper than I would. So thank you.
Absolutely.
Sheena, my question for you in terms of what to go to market for a big health system, would you consider like a white label approach here, or is the KEPT brand and go to market kind of vertical from a health system brand, if that makes sense?
So actually how we work with health vertical systems is basically individuals come to us when they have I'll just say broad-based research question that they need answered. So if you're noticing something in your EHR data or your claims data, or there's just topic out there. So we usually start with a discovery, and then we can move into more longitudinal studies. That may be surveys, it may be different types of testing, things of that nature. So it's a scale process. Yeah.
Got it. I love that. I was thinking the opposite direction from a consumer perspective, because I think a lot of big health systems are looking to differentiate in women's health. And I think a partnership like this could definitely create a lens of differentiation.
Yeah.
That context.
That's a great part. So we do partner with different organizations when it comes to the consumer facing. So with one of our clients, it was more creating, I'll just say, experiences, connect with women with their members through regional events. And then sometimes it's, like I said, larger events where women are gathered. And so we're able to create these different experiences, have a section where we do focus studies, the surveys, even like the hormone spit test that we do as well.
I want to pick up where Jeremy was going, maybe, or started to, is as a health system in terms of research, I'm not sure we would use this for clinical research because of the whole biases in how you collect the information, but I would be interested in using it if where I think you started to go, or Jeremy started to go, if we had a question that we wanted answered, could we use your firm to do that, conduct that, and then compare it to other markets that you've done it? That, if you would have pitched that to me, I would be more interested than how you presented it, because it wasn't clear that as a health system I would use it. But where Jeremy started that question, if you pitched that, I'd be like, yeah, I could probably, as a system, I could probably use it. So just something to consider in terms of who you're talking to and how you throw your information, because you have a data set. It's just how people want to access it.
Yeah, it's a data set, and it's also great points. Back to say great points. I'll definitely take that into consideration. But it's a data set, but you're also we're basically turning the head on the real world data collection platform that already exists, basically, right? And so what we're saying is you add women's health, but you're only focusing on reproductive. Like we talk about diabetes, autoimmune diseases, real world experiences, but I totally see that where I was focused on how we collect the data more, like to give you that insight versus I kind of brushed over like what you use it for in the departments. Yeah.
Yeah, I'll just chime in just one thing here. This is where I probably need like my person over data analytics, but I think the more data that we can capture on the populations we're managing, I mean, we're finding more use cases for that data. I'm probably not the best expert to say how we would use this, but I do feel like the wearable, especially space, I think there's a lot that we could do with that. I'm not sure what all at the moment, but I think there's something here, something about population health in general. But
yeah, definitely.
Yeah.
Okay, I think that brings us to time. So thank you so much to all the founders who presented today, but special thank you to Kevin, Phil, Zane, and Jeremy for your time and your insights. We will make the connections offline that we heard you wanted today, so look out for those emails, and I hope you all have a wonderful day. Thank you.